I'm Dr. Thomas Locke. As usual, my subject today pertains to saying something because somebody's got to say it. I get asked questions almost daily about why don't you take insurance? And I believe that someone who doesn't participate in the various healthcare plans is in a better position to honestly answer not only that question, but all kinds of questions about our health insurance system today. Now, basically, first thing I want to emphasize is health insurance is not insurance anymore. The insurance company has almost no indemnity when it comes to treating you or paying for your health care. When you think you have health insurance, what you actually have is a health plan, which means some businessman made a deal with another businessman who also had input from another businessman, one representing your employer, one representing an insurance company, and probably someone from a pharmaceutical company. But all these folks decided what would and would not be covered. So you have a plan that covers what these three entities, non-medical entities, have decided you're entitled to. Now, the thing that will be obvious if you look at it carefully is that the people who make the decisions are not your doctor, okay? And what's worse is even your doctor isn't your doctor anymore. Unfortunately, very few doctors are independent entities who work for their patients. A doctor has been reduced to little more than hired help working for a big hospital, working for insurance companies even, working for large groups run by non-medical people. But the bottom line is there's a very rare physician in practice nowadays who's a private entity able to speak up and be a patient's advocate. The patient is a cost of doing business for the employer for whom your doctor works. And a lot of things that don't make sense will become abundantly clear if you keep that thought in mind. Now, a worse problem is, I shouldn't say this, because once upon a time I was an advocate for, and I still am an advocate for physician extenders. But the epidemic of using the term provider has caused the quality of care to be greatly diminished society-wide. And what do I mean by that? Now, some of my best friends and closest associates happen to be nurse practitioners or physician's assistants. But about a decade ago, these same businessmen we were talking about a while ago decided that it would be nice to create a public relations situation where a PA, a nurse practitioner, an MD, a DO would all be essentially equivalent. So they started calling everybody a provider. Now, my message to my fellow physicians out there is you need to be insulted, offended, and say something when somebody calls you a provider. If you have an MD or DO behind your name, you didn't go to provider school, you went to medical school. And being lumped in as the equivalent of a physician's assistant or a nurse practitioner and the compensation implications related thereto is an insult to all concerned who were, and nowadays in economic terms, stupid enough to spend 14 years training to do what you could have done in 4 or 5 years to become a nurse practitioner or a PA. So the bottom line is, when we all became providers, the quality of care suffered greatly. So I hate it when I hear the term because a lot of my friends are offended. and I am offended for them. But a lot of folks who wear white coats are doctors, okay? But they get to practice medicine as if they really were doctors. Now, the real challenge is when doctors start to become doctors because they practice what's covered and not what's good for their patient. And in that situation, the MD or DO may as well be a PA or an NP. The bottom line is we have to understand these realities as healthcare consumers. And a lot of things that don't make sense become abundantly clear if we keep these realities in mind. Now, I want to spend time in another video another day talking about things like RVUs and capitated plans, but all these concepts are ways that the businessmen who run medicine now control their hired help. You know, RVUs is something if you really want to get a buzz out of somebody, if they work for a big hospital or an HMO or a large group practice, ask them, do you get compensated based on your RVUs? Okay, basically they get paid more for doing things to you, doing procedures, ordering profitable tests, and nobody gets paid for sitting down listening to you or asking and answering you a bunch of questions that don't generate revenue for the boss man for whom the MD works. So the real scam as far as the capitated plans, and I'm going to spend more time documenting these facts before I talk about them again in another video. But when you talk about copays, there's such a thing as a capitation where a physician gets, I won't use that word, persuaded to work for a fixed fee, which can be as little as $5 or $10 or $20 a month, every month. Whether you see the patient or not, your compensation pretty much remains the same. So to make it look like they're paying for a fee for a service provided, they came up with this copay scam where the patient has to pay a copay. But what you need to realize with some of these capitated plans, that's all the pay that the doctor gets. Now, you try to get a plumber or an electrician or a mechanic to work on your vehicle or your air conditioning or your toilet for what they pay in copays, and you'll understand why your doctor isn't glad to see you anymore. But I'll do some digging and documenting and come up with better verification of which plans do what. And I'll start calling names in future videos. Now, for general terms, we need to understand what in-network means, okay? When someone is in-network, they basically agreed to work for a lot less. They've basically agreed to be pimped by whoever designed the network. And when someone is out of network, what that really means is they've refused to be pimped. They've refused to work under the conditions that the in-network people have said they have to work. So it's not a bad thing when somebody's out of network. It's not a good thing when somebody's in network necessarily. But I think a lot of people who provide good care and they remain in network really ought to be elevated to some kind of noble level for donating their time and working for free. Maybe a Mother Teresa award or something if you do good care and you do it in network. But anyway, let's talk about Obamacare. Obamacare was kind of a step in the right direction. At least it was intended to provide care for people who don't have health coverage. It was good to address things like pre-existing conditions. But the real problem with Obamacare was Big Pharma, the insurance industry, and a whole bunch of politicians were in the conversation. Nobody who sees patients for a living was involved in the conversation, even when they gratuitously got a few MDs involved at the last minute. These are guys who are politicians and academicians who really don't see patients for a living. So the obvious flaws and the obvious inadequacies of Obamacare can simply be explained on that basis. Now, the other myth that we have to address is the electronic health record is a better way to document health coverage. I see the electronic health record as the last nail in the good medicine coffin. If you look at documents generated by one of these health records electronically, when you finish reading dozens and dozens of pages, you don't have any more information than when you first picked up the record. Now, most often you can't even print it and have something to refer to. It's electronic. But these records are generated by a bunch of pointing and clicking and matching symptoms to ICD and CPT codes so that somebody can get paid. It may or may not have any bearing whatsoever to what really happened in that healthcare encounter. The sad truth is, preoccupation with creating an electronic record has cost us the luxury of basic stuff like physical diagnosis. Nobody gets examined anymore. The laptop has become the patient. You look at an encounter from afar if you accompany a loved one to a medical office visit and observe how much of the time the person's typing on the laptop, observe how much of the time they're communicating with the patient, and observe how much of the time they even touch the patient. And don't get me to talking about telemedicine. That's the next subject. But the laptop is now the patient. The patient is almost in the way because some poor soul has to generate an electronic record so some bean counter can generate a bill so some big hospital or some big group practice or some big whatever entity can get paid. And if this person who's generating this electronic health care record doesn't do a good job of getting their boss paid, they will be replaced. So it is no mystery when you go to a place nowadays and you see a different face every time you go for your health care. So understand that the electronic health record has become the focus of attention, and the patient is no longer the focus of attention in these settings. That's just the sad truth. Now, my other gripe is with the social workers who usually work for well-meaning, well-intentioned, and very often government agencies, and they are quick to tell the patient that Medicare is going to pay for everything, or Medicaid is going to pay for everything. Everything is covered. Nothing could be further from the truth. The reality is, Medicare defines what they will pay for a given service, and if one is a participating physician or provider, they agree to work for what Medicare says your service is worth. Then Medicare pays a percentage, 80% on most things, of what Medicare says the service is worth. The participating provider, I hate that word, the participating provider has to write off the difference. So if you look carefully at these bills for what adjustments they make down to what Medicare says a service is worth, and then Medicare only pays a percentage of that, then you understand why the people don't want to accept new Medicare patients. It's unfair. Now, the Medicaid situation in some states is worse, some states is better. Basically, you can imagine, this is America. People aren't going to go out of their way to provide the quality of care for poor people that the quality of care available to rich people is provided. So we have to accept that when the government's paying for everything, whether it be the state or the federal government, your quality of care is going to be compromised. And anybody who says otherwise is being dishonest. Now, here's where I'm going to really get in trouble. And I don't care. But around the time when I entered med school, that would be 1974, a majority of doctors were male. My graduating class was 50% female approximately. And nowadays, more than a majority of graduates from medical school are female, okay? Now, that trend was concurrent with what I will call the un-Americanization of American medicine. Males are no longer the dominant force in medicine. Revenues in the specialties dominated by women especially have gone down, 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 down. So I know that it's a function of gender. It's unfair. It's not just true in medicine, but women in most professions are paid less than men in the same professions. That's even true for nurses. I saw statistics recently where male nurses get paid more than female nurses on average. Now, I've had the privilege of working for a few years in yet another profession where I observed this same phenomenon. And I'll talk about real estate for a hot minute. Once upon a time, most people who did real estate were men. As more and more women started doing real estate, the commissions and the overall compensations went down, down, down. So I'm not saying that women aren't as good as men. Women might do a better job in some situations, a lot of situations, I'd even say. But the reality is they're willing to work for less. So the decision makers, whether they be male or female, are going to obviously make it so that if a female's going to work for less than a male, then the female's not only going to make it so they get paid less, but they're going to also reduce the likely available compensation for the males. So my message to female physicians is it's time for these ladies to man up and not accept the things thrust upon them in the way of reduced compensation. Your service, your training, your qualifications warrant you being paid more than what a bean counter says you're worth. And as long as they can get away with people working for what they're willing to pay, then these ruthless businessmen who only care about their stockholders, they're going to keep doing it. So it's nobody's fault but the physicians who allow the bean counters, the stockholders, and the CEOs and the CPAs and the MBAs or whatever else the letters you want to talk about. These folks are making decisions that MDs ought to be making. And because they're not, we have the situation that we have. Now, I do believe that it's a good thing culturally that more and more physicians happen to come from countries other than the United States. But the motivation is not because anybody is benevolent or they're really wanting to train people from other countries. They do this because these physicians are willing to work for less. Even when they work harder and they see more patients, they're still working for less per patient. And that reality is something that has compromised the overall quality of care. Now, my other gripe is with the employer-based health insurance model, okay? We have gotten into this back from a time when unions basically were the driving force behind getting health care coverage through your place of work. People don't spend 20, 30 years working for the same employer anymore. That alone is reason sufficient to change the source of where our health care coverage comes. When you change jobs, even people who can't afford it end up spending extended periods of time with no coverage. So I think the employer-based health insurance model needs to go the way of the Model T and the Edsel because it doesn't fit the kinds of realities we deal with in our society today. Now, one of the other issues that I overlooked briefly that I have to address is the training of physicians. When I was in medical school and when I was in my residency, we learned by taking care of real, live, human patients. YouTube videos, laptops, video games, and more importantly, reduced work hours allowed have compromised the amount of experience that physicians in training get with hands-on care. There was a time when a physician's eyes, the physician's ears, the physician's hands, these were essential tools. These were special. People who went through medical training see things that other people don't see, hear things that other people don't hear, and they can use their hands to define things that other people are not able to do. Not anymore. These young doctors, if it can't be done with a mouse or a keyboard, if they can't see it on a screen, they're clueless. And people wonder why they're running up the cost of health care. They have to order a test so they can create an image that you can see on a screen so they have a clue about what's going on. Once upon a time, we would always examine our patient, get a good history, and predict what x-rays would show. And once in a while, we got surprised. So you still need these imaging studies, but you can't be totally clueless going into a diagnostic workup and depend exclusively on what an x-ray or an MRI or whatever is going to show. If you can't talk to somebody, examine them, and have a real good idea what's wrong with them, they might as well see a physician assistant or a nurse practitioner or something. Anyway, that's enough about that. But basic point I want to make is I got to a point where I had to say these things when this COVID-19 virus is forcing us to get into telemedicine, okay? People who never learned physical diagnosis in the first place, people who don't gather any meaningful information using their hands, using their ears, talking to people, people who are used to getting information from a screen, they'll gravitate to this telemedicine in a heartbeat. But there's all kinds of information that you cannot pick up on. You can't identify smells. You can't identify dullness to percussion. You can't hear wheezes realistically. Well, some people can't do it with a stethoscope nowadays. But the point is, examining people hand to person, hand to body contact. That used to be a useful source of information. Yes, it's nice to have ultrasounds. Yes, it's nice to have CT scans. Yes, MRIs are a wonderful thing. But if that's the only way you can get some information, because you can't do physical diagnosis, then obviously the cost of healthcare is going to go through the roof. I don't know why this is such a mystery. Now, I will say there is hope, okay? I never thought that I'd be an advocate for any kind of nationalized health system. I've spent decades opposing the whole concept of universal health care, mostly because I knew it would be brought to us by the same people who brought us these other not-so-natural disasters like Medicare, Medicaid, the VA, and all these other government-run healthcare disasters. But if you look at how the businessmen and the insurance industry and the pharmaceutical industry have corrupted traditional insurance, I have to say now that a universal health system would be better for society than what we have now. And I truly wish, maybe I shouldn't say this, but I wish I had been consulted when it came time to explain Medicare for all. If I had been asked to explain Medicare for all, Bernie Sanders would be our next president. What he avoided, unfortunately, was talking about the tax increase that would be necessary in order to have Medicare for all. It's unavoidable. That's just a fact. It's not politically smart to talk about it, but you can't have Medicare for all without an increase in taxes. However, the obvious thing that should have been promulgated is that the amount of the tax increase on a per family basis is less than what most families are paying in their stupid deductibles now. People have $2,000, $5,000, and even higher deductibles now. Nobody's tax is going to go up more than $5,000 a year. Not to mention that with Medicare for all, the health premiums go away. That's another $1,000 every month. So if he had explained it in these kinds of terms and just made an honest reference to what the tax implications are and how it's actually a net tax savings, I think his mistake was he didn't explain it very well. But meanwhile, I don't know that Medicare for all will ever come about. I do believe that something better than what we have now is necessary. Now, if I'm a healthcare consumer, there are two other things I want to say we should be familiar with. One is the concierge model, and a lot of people don't like that term, but I prefer the term retainer fee-based medicine, where you pay your physician, I'm not going to use that other P word, you pay your physician a fee, fixed fee, for 1 year of service, and he'll take care of you, or he'll take care of you and your family for something less than 1 or 2 months of your premiums. And basically, you obviously can put your savings in terms of premium dollars in a medical savings account. And when you need something expensive, like an MRI, or if you have to have surgery, the money you put in premiums would be available to pay cash for these services. More and more providers are being much more willing to accept cash payments rather than fight with an insurance company. Self-pay no longer means indigent. Too long have we assumed that the terms were synonymous. Self-employed people making very good income would save a lot of money paying cash for the services rather than being ripped off by trying to adapt to some health plan that some businessman designed without you in mind. The other issue, in addition to the concierge model, medical savings accounts, is a lot of people are finally talking more about preventative medicine. And even the HMOs are pushing prevention because that saves them money too. So preventative medicine is another area where we need to put more energy. And I think staying healthy is a better focus than trying to have coverage when you get sick. But anyway, I hope I don't ruffle too many feathers with these divergent opinions, but I say these things in the spirit of somebody's gotta say it. So I thank you for your time. I thank you for your attention. I look forward to the opportunity to share with you more information in our next Wise Medical Minute.
Thank you for listening to the Wise Medical Minute with Dr. Thomas Locke. Dr. Locke addresses current events as well as important medical issues using responsible, unbiased journalism approach from a medical perspective. We invite you to submit questions or comments or suggestions for future topics by email to info@wisemedicalcenter.com. Again, thank you for viewing the Wise Medical Minute.